Hello, everybody. Thank you so much for joining us today. My name is Angela Peacock, and I was trained as a social worker and a therapist, but I do not practice. And I'm also a subject of the film Medicating Normal. I volunteer doing outreach for the film, and I host conversations like this one today. This is our 48th interview, and today our guest is Irving Kirsch, PhD. I'll just give you a little background. I have been a huge fan of Dr. Kirsch for a very long time. When I read his book, I was in graduate school, and it just opened my mind to like so many different possibilities, and it helped me be a better critical thinker about research. It helped me think about other forces that impact how we perceive medications working. It also was kind of disappointing, like, oh my gosh, I was taking these medications for so long and I thought that they were working. Maybe there was more to it than just that. So I'm super excited about today's conversation, and I'm just enamored by him and his knowledge, and just can't wait to get into it. So let me read his bio, and then we'll get in there. All right. So Irving Kirsch is an associate director of the program in Placebo Studies and the Therapeutic Relationship, and a lecturer on medicine at the Harvard Medical School, Beth Israel Deaconess Medical Center. He is also Emeritus Professor of Psychology at the University of Hull, UK, and the University of Connecticut in USA. He has published 10 books, more than 250 scientific journal articles, and 40 book chapters on placebo effect, antidepressant medication, hypnosis, and suggestion. He originated the concept of response expectancy. Kirsch's 2002 meta-analysis on the efficacy of antidepressants influenced official guidelines for the treatment of depression in the United Kingdom. His 2008 meta-analysis was covered extensively in the international media and listed by the British Psychological Society as one of the 10 most controversial psychology studies ever published. His book, The Emperor's New Drugs: Exploding the Antidepressant Myth, has been published in English, French, Italian, Japanese, Turkish, and Polish, and was shortlisted for the prestigious Mind Book of the Year award. It was the topic of a 60-minute segment on CBS and a 5-page cover story on Newsweek. In 2015, the University of Basel, Switzerland, awarded Irving Kirsch an honorary doctorate in psychology. In 2019, the Society for Clinical and Experimental Hypnosis honored him with their Living Human Treasure Award. Welcome, Dr. Kirsch. What do you think when I read all that? What a career.
Yeah, who is that? That's so I wonder, I'd like to meet this person.
Who's that guy? That is so amazing. You just like, wow. Amazing. So before we get started, I want to hear, what did you think of Medicating Normal?
The film?
Yes.
I loved it. I recommended it to people. I showed it to people. I got your permission, was able to show it to a film discussion group that my friends and I have here. Marvelous job.
Yeah, we love it. We love it that you're a fan too. All right, so I have lots of questions for Dr. Kirsch, and as always, you can ask questions in the comments at any time, and I'll try to fit them in where we see fit. So let's just get started with the first question. Dr. Kirsch, what brought you to study psychology and then later placebo studies? And can you explain a little bit about like what exactly is placebo studies?
Okay, well, I'll try not to make it too long-winded. I got interested in psychology while an undergraduate at college, and it was taking an introductory psychology course, and I just loved the course. And one of the things I found most interesting was learning theory, and particularly the learning theory of Edward Tolman. Tolman was different than most other learning theorists in that he had a role for cognition as opposed to just a mechanistic conditioning process as the basis of learning. He did his research with, I like to say, one paw tied behind his back, because he's studying mental events, expectancies in rats. Did a marvelous, persuasive job on that. Switched my major from music to psychology. Graduated from Los Angeles City College, which is a 2-year college where I had that first course. Went to California State University in Los Angeles. Started getting interested in behavior therapy, which at that time, we're talking about now early 1970s, and was basically the most well-known was systematic desensitization for phobias. Mm-hmm. And that was supposed to work by means of a conditioning process. And I got convinced that indeed a lot of people could be helped overcoming anxiety, phobic anxiety with that process, but doubted the conditioning explanation, being influenced by Tolman, the cognitive psychologist, and began having the hunch that, you know, to the extent that this treatment works, it probably has something to do with people's beliefs and expectations. And that led me, of course, to the placebo effect. And so I started studying the placebo effect, first in the area of anxiety and then in general. And that became the basis of my career, the influence of people's beliefs and expectations on their experience and their behavior has been the uniting theme of the various research work that I've done.
So that expectancy, just listening to you say it like that, is that like right before the rat pushes the lever, it knows that if I push that lever, I'm going to expect something to happen. That little space.
Yeah, and even what it is that's going to happen. And when it runs through a maze, it develops a cognitive map of the maze. So it's not just learning to move in particular ways. You can make movement impossible by doing things like flooding the maze so they can't run it. So they'll start swimming. They're not doing any of the same movements, but they'll make the same turns because they've learned where the food is.
Amazing. Wow. So then what took you from normal placebo studies over to the antidepressants?
Well, that was talking to a graduate student of mine, Guy Saperstein, and graduate student then, he's now Professor Guy Saperstein. And we were talking about the placebo effect, we were talking about depression, and came up with the idea that there ought to be a strong placebo effect in the treatment of depression. Now, I hadn't seen the data at that time, as both as a therapist and as a researcher. I assumed that antidepressants worked like people thought they did. So I didn't doubt that. I had, as a psychologist, I can't prescribe, but I had referred some clients to colleagues who could prescribe antidepressants while continuing to see them in therapy. But it seemed to me that there ought to be a strong placebo effect in the area of depression. And one of the reasons for that is that a core feature of depression is a sense of hopelessness. And one of the things that people can get hopeless about is their own feelings of depression and the sense that I will never get out of this. I will never get better. That's hopelessness. So anytime you have something new that might change that, that can instill a sense of hope.
Wow.
That is what's behind the placebo effect. So what we were expecting to find, we decided to do some research, did the first meta-analysis, maybe the second meta-analysis that I had ever done. The first one was not on antidepressants. We looked for studies looking at antidepressants and placebos. We analyzed, we looked at how much improvement there was in the drug condition, how much in the placebo condition, and we looked for studies that also had a no treatment control group. The reason for that was our interest was not in investigating antidepressants. As I said, we just assumed they were, but we were interested in the placebo effect. And just like you can't know what the drug effect is without having a placebo, the drug effect is going to be the difference between the response to the drug and the response to the placebo. You can't know what the placebo effect is without seeing what happens if you don't give the placebo. Found studies in which some groups, some people were randomized not to get any treatment at all, not even the placebo. And we did that analysis, we published it, and what we found, and we found that, first of all, it didn't surprise us, is there was a very large placebo effect. About 1/3 of the response to the active drug would have happened even without the placebo.
Wow.
Another 50% of that response was a true placebo effect. You got that when you got the placebo, but not if you weren't given the placebo. But then the surprise was that left only 25% of the response left over that you couldn't explain as a natural history or a placebo effect. That was the most that the drug response could be, and that was very small.
Mm-hmm.
That was very small for something that was being hyped as a revolution in the treatment of depression. And that got my interest focused on, well, wait a second, not only is there a strong placebo effect, but there doesn't seem to be much of a real drug effect. And that led to the subsequent meta-analyses and studies that my colleagues and I have done together.
Amazing. What a discovery that is. So let's take it back one step just for the people that may not be familiar with what exactly is the placebo effect. I kind of touched on expectancy, but can you teach put your professor hat on for 1 second and just tell people like what's the difference between placebo effect, expectancy theory, what a nocebo is, and maybe what properties of antidepressants or other treatments make us more likely to respond.
Okay. So first of all, in answering that, let me make a distinction between placebo effect and the placebo response. Very important differences. And the difference is parallel to the difference between the drug effect and the drug of response. Response is what happens when you give somebody something or don't do anything at all. It can be a response to nothing. So you give someone a drug, whatever happens, that's the drug response. You give someone a placebo, whatever happens, that's the placebo response. But as you've just seen from the example I gave in response to your previous question, the drug response may not be a drug effect at all, or it might be partially a drug effect. That's why you have the placebo control. The placebo response, what happens when you're given a placebo, is partially due to the placebo effect, but part of it would have happened even without being given a placebo. So that's the placebo effect is the difference between giving the placebo and doing nothing. The drug effect is the difference between giving the drug and giving a placebo. So those are what the placebo effect and placebo response are. Now I have to go back and remember the other parts of your
question. Yeah. The other part is, somebody's already asking about, I understand how the placebo effect can work because you think your antidepressant will help you feel better, but in the opposite way, when you taper, that would be the nocebo effect. As you slowly take the antidepressant away, do you expect something bad to happen? So really, what's the difference between like a placebo response and a nocebo?
Okay, so the placebo effect is the beneficial effect of thinking that you're getting something. And the nocebo effect is the negative effect, the undesired effect of thinking that you're getting a substance that can produce those effects. So you can get from a drug side effects that are due to the drug, but you can also get adverse reactions that have nothing to do with the drug, and they might be nocebo effects. You think that the drug causes this. If it's something good, we would call it a placebo effect. If it's something bad, we would call it a nocebo effect. You have a real negative drug effect when you have adverse events that are more common in the drug group than in the placebo group.
That's amazing. So one thing that relates to this that I read in your book that was fascinating to me was like the difference in color in a pill can have a different effect. Can you talk about different kind of treatments, medications, hypnosis, acupuncture, like different things that make us more likely to experience a positive result or stronger placebo response?
Yeah, so there are a lot of things. One is the condition being treated. So the placebos do not affect, if you give a placebo for infertility, you don't get any placebo effect. It's hard to find any drug that'll give you an effect either, but you don't get a placebo effect. On the other hand, if you're treating Parkinson's disease, you can get a fairly strong placebo effect. You get an even stronger effect with things like asthma, and even stronger with anxiety disorders, and with depression. You get this gigantic placebo effect, leaving very little room for any benefit from an actual medication. So the more that there are subjective components involved, the easier it is to get both placebo and nocebo effects.
It's fascinating. One thing I've always wondered, this wasn't a predestined question, but it just came up again. Like, how do we know the difference between I'm giving you a physical pill to take that you're expecting is going to make you better, and the combination of just being enrolled in a clinical trial or being in the hospital where people are caring about you and you're getting your meals? Like, can we even parse that apart? Like, how much of it is it just being cared for?
We can. We do that by having an additional control group, which is a group that gets everything, the setting and all of that, but not the placebo or the bona fide treatment. A very lovely study done at UCLA with a 3-arm design like that. And they look just having a good therapeutic relationship alone with no treatment being given, just the warmth, the meeting, how is it going now, getting a placebo and getting an antidepressant. There was very little difference between the placebo group and the antidepressant group, but both of them had a much better response than people in the no treatment, just a therapeutic relationship group. And that's how we know that this was a placebo effect, not just a placebo response. And there are other things that make a difference. You mentioned color. So blue pills, as it turns out, tend to be more effective for, yes, relaxation, sleep. Red pills are better for being energized, for pain relief. So that can make a difference. 2 placebos are more effective than 1 placebo, just like 2 drugs are more effective, 2 doses of a drug are more effective than 1 dose. That's true of a placebo as well. Capsules seem to be more effective than pills. Injections are more effective than capsules. Intravenous infusions are even more effective. And of course, the most powerful placebo of all is surgery. And there have been studies with sham surgery being used as a control for the real surgery. That's where you get the best placebo effect in Parkinson's disease. And many surgical procedures have run into what the physicians in that area call the sham wall, which is they can't get a treatment that works any better than a sham treatment, where you open the person up, you close them up again, and you don't do the surgical intervention. So yeah, different placebos have different effects, different doses have different effects. Routes of administration are particularly important in eliciting a strong placebo effect.
It's amazing to me. It blows my mind. It makes me really appreciate, I mean, and we don't even know the mechanism of where that's happening at, right? We just, something about human consciousness, the power of the mind. Is that really the basis of it?
Well, we're looking at this, we're doing a lot of studies now. So one of the things we've been able to do in brain imaging studies is see what lights up in the brain when you give a placebo. And it depends on what it's a placebo for. So if you give a placebo for pain, the anticipation of pain relief has an effect on areas of the brain that are important for processing pain. And people who report experiencing less pain after being given a placebo treatment, they actually show that you can see that change in pain through brain imaging. So yeah, I guess it's all in the head, but that head's part of the body. So
right. Wow. That is fascinating to me. It just blows my mind. All right. So we are getting a question, and 2 questions about this your particular answer is, what about flavors? Like, I remember as a kid, the pink amoxicillin that you would drink, or they also said dose sizes. You kind of touched on that. Like, if you get more of a drug, it actually works better. Can you, and then the next person said, isn't sham surgery a bit unethical?
Okay, well, so those are a couple of different questions. One's fresh is the ethics of the sham surgery. So what you need to know about that is, first of all, sham surgeries are done with informed consent. So the person knows that they may be getting a real surgery, they may be getting the sham surgery. You could still argue, well, but cutting someone open, even with their consent, isn't that a problem? And then you can ask the other question. What happens if you're doing a surgical procedure and you don't know it's sham? If you don't have a sham surgery control, you'll never find out. And we have that happening in the history of surgery and placebo effects. The first ones being around 1958, 1959, when they used to do, they don't do this procedure anymore, for angina, they used to do what was called mammary ligation. They would tie off the mammary artery, and they were reporting success rates of somewhere around 80%. And two different research labs, medical research labs, decided, well, how much of that is really due to tying off the mammary artery, and might there be a placebo effect? And around the same time, both of them independently did studies with sham surgery, where they had a group where they cut people open, they didn't tie off the artery, they closed people up again, they got their informed consent to do that. They found that with that one, they got no significant difference between the two. People improved to a great degree in both the real and sham surgery group. There was no benefit to the actual surgery. Now, they don't do that surgery anymore. What if they'd never done that study? They would have been subjecting hundreds of thousands of people to a surgical procedure that was doing nothing surgically for them. So maybe it should be ethically required that you find some way of evaluating. That has happened more recently too. There's a procedure that's still done called arthroscopic surgery for osteoarthritis of the knee. First sham surgery controlled trial of that was done in 2002 or 2004. I don't remember which of the two dates, done in Texas. 2 weeks after the surgery, they found that people who were given the sham surgery were doing significantly better at walking and climbing stairs than people who had gotten the real surgery. And they said, well, that might be they were spared the surgical trauma. A year later, that was still true. Yeah. Sham surgery patients were still doing a little better than the real surgery patients. And 2 years later, there was no difference at all. The British Medical Journal has since come out with a clinical guidance, noting that despite these studies showing the surgery didn't work, their rates of performing that surgery in country after country continued to go up. And they issued a guidance saying this surgical procedure just should not be done on hardly anyone.
Wow. It's fascinating. So we're going to go back. I want to go back to talk about the Hamilton rating scale a little bit. I think I forgot to include that, but I think it's really important. So I'll try to sum it up that when you're taking a drug, part of that, like you said, 50% is just placebo. And then another 20% is, and wait, what do I have? Help me.
50% is a placebo effect. About another 25% is what would have happened even without the placebo, just natural history, regression towards the meanness, things like that.
So then the leftover 25 would be a drug response, but that's usually measured on the Hamilton rating scale to see like, okay, how much has your depression improved? So then we might say a person had, and I know you know the research better than anybody, but we might expect a person to improve 3 points. Let's just say, I think it's like 1.7 or something, but a couple points on this Hamilton rating scale. But then you found that point change isn't really clinically significant because your therapist doesn't even notice if you've improved or not. So can you explain that a little better than I just did?
Yeah. So first of all, what those figures are talking about are the difference between the real drug and the placebo. In terms of the responses that you're getting large responses to the real drugs. On the Hamilton scale, the real drug might give you 8-10 point improvement. The problem is not that people aren't improving. The problem is it's not the chemical in the drug that's causing the improvement. So you get a drug response of more than placebo response of more than 8 points. What's very small, what's less than 2 points, is the difference between the response to the drug and the response to the placebo. And that difference on a Hamilton scale is clinically meaningless. It's a tiny, tiny difference. It's clinically meaningless.
And that's also, I think, doesn't that relate to even that little drug effect could be caused by the unblinding of the patient, knowing that they're given an active drug?
That's very true. And that's extremely important. We know when we ask people to guess what treatment they've been given, they tend to be very accurate if they are in the drug condition, and much less accurate if they're in the placebo group. And that's probably because they're noticing the side effects and thereby being able to know that they are being given a real drug. Clinicians who are doing the ratings, who are administering the treatment, they break blind even more than the patients in the trials do. They know, even though they're being kept blind, just from meeting with the patients, they can tell which drugs have been given to, and when there are studies with 2 active drugs in a placebo, the clinicians can also tell you which active drug the patient got, because different active drugs have different side effects. So that small difference may be a boost, due to a boost in the placebo response, a boost actually in the placebo effect, due to breaking blind, to think, okay, I knew I might get a placebo, I know I might get a drug. Oh, they told me my mouth would get dry, because as part of informed consent, you have to say what the side effects of the known side effects of the medication is. They told me my mouth could get dry. And I'm feeling very, better. Oh, my mouth's dry. That's great. I must be in a real drug condition. Hooray.
Got it. Yeah. I'm less depressed.
Yeah, I feel better already.
Amazing. That is amazing. Okay. We have a very smart audience because they are putting together a lot of things, and some of it's powerful and some of it's really upsetting. But this person asks, if the placebo effect is so powerful, does this mean that all the medications that have any effect on the brain are useless, especially since they carry so much risk?
Okay, I can't talk about all of the drugs that can impact the brain, because I haven't studied all of the drugs that may have an effect on the brain. So I've got to limit myself to things where I've seen the data, I've looked at the data carefully enough to make a claim. So I can say this for antidepressants, I can say it for the various classes of antidepressants. I can say that for the use of antidepressants in the treatment of anxiety, as well as in the treatment of depression. I can't answer that question. My assumption is, my guess is, that yes, there are a lot of drugs that work for a lot of things, for a lot of reasons. Antibiotics, for example, I would be very surprised if they don't work for infections. Depends what kind of infection, but rather viral or bacterial. But I have no reason to doubt that they work. But again, could be wrong about any particular drug, have to look at the data.
Yeah. So another person's asking kind of the same question, but basically they're saying like their doctors don't believe them when they're harmed by a medication, because I guess they don't believe that there's an effect. So I don't know if you have any place to say anything about that, but just the disappointment of understanding like what is all going on.
Yeah. Well, I can understand that problem, my end of it is the couple of times that physicians have tried to prescribe antidepressants to me, even though I wasn't depressed, but they thought it would help for that. And I remember I had my partner with me at a consultation years and years ago, and the doctor said, have you ever considered taking maybe how about a prescription of citalopram? My partner started laughing and said, hey, you don't know his research, do you?
Oh my goodness. That's funny. Yeah. So that's one of my greatest questions though. Like how has your, I know when your work first came out, especially like when it hit 60 minutes, it was a little explosive and controversial and people were emailing you. And so how, I guess, first question is how has that impacted, how was it received? How has all your work been received? And then has it informed or changed clinical practice at all? If so, how? If not, why not?
Well, there's still a big controversy. It's still controversial. People are fighting about it. Many different labs replicated the meta-analysis that my colleagues and I had done, or meta-analyses, because we've done a couple of different ones. And many of them are attempting to show that it was wrong, and everyone comes up with the same numbers.
Wow.
Most recently, an analysis was done in-house at the Food and Drug Administration, at the FDA, presented at a conference on all of the data ever sent to them by drug companies for the approval of antidepressant medications. So it's a patient-level meta-analysis, which means they had the raw data from each patient, and we're talking about over 73,000 patients now, and they got virtually the same results that we did, and at least one measure, the results were identical to within 1 decimal point. So the data are clear, and everyone gets it over and over again, and the larger the data set, the more reliable it is, but it's the same numbers that we get with that we reported with a very small data set initially. So the debate continues. Medicine can be slow to change. And the example of that would be one that I just gave about the surgery for osteoarthritis of the knee. They're still doing it. There are no data showing that surgery works better than sham surgery. There are at least 2 trials showing that it doesn't work any better than sham surgery. Physicians still do it. It's going, and that's why the British Medical Journal wound up coming out with its guidance that please stop, don't do this anymore. Once you get to a point where you're believing, doing, recommending anything in science, even outside of the realm of treatment, you believe in it, and it's hard to change your beliefs. The more time you spent, there's a very important book, probably the most influential book on philosophy of science from the 20th century, The Structure of Scientific Revolutions, Thomas Kuhn. And he talks about paradigms and paradigm shifts. The title of the book is The Structure of Scientific Revolutions. How do these revolutions occur? And one of the things he points out is they occur slowly. And they don't occur by changing the minds of the people who have been believing in the old paradigm for generations. They change by new young researchers, clinicians coming into the field, looking at the data with fresh eyes and without having the baggage of their own previous beliefs and what they have said to, how if you've done this procedure for a bunch of times and convinced patients this is the right thing for them, it's hard to say, gee, I was wrong all of those times.
Right. It's fascinating. I can think of some of those researchers. You're one of them, but also like Mark Horowitz, Michael Hengartner. There is a few of those really great researchers doing this work right now.
Yes.
Amazing.
And that's one of the things that I've seen happen that's pleased me a lot, is to see researchers come into the field, younger researchers, and carrying this work further. And then, of course, there's a researcher who's not someone who came in after this, but actually before this, and that's Joanna Moncrief, whose work has been excellent and extremely important in this area.
Totally agree. Yeah, she was one of our guests maybe 20 episodes ago. Amazing. All right, so this is my little controversial question. I met you originally at the ISEP conference in Toronto right before the pandemic, and that was my graduate school present to myself, was to go to an ISEP conference. ISEP is International Society for Ethical Psychology and Psychiatry, and Dr. Kirsch was the lead speaker. And during his speech, a couple times he said the word relapse, and I just have my own visceral reaction to that word, because there's a confusion, it seems to be, from just being on the other side of this. Just, I watched myself decline after I came off of an antidepressant, but I knew it wasn't my old depression coming back. It felt qualitatively different. And so when I hear that word relapse, I'm like, oh gosh, like they have it all wrong. This is a drug effect. This is a withdrawal effect. It's not the original condition coming back. So I approached Dr. Kirsch and tried to talk to him about it, but I was extremely nervous. But then Laura Delano kind of talked to him about it later. So I wonder, how has your perception changed about that, withdrawal versus relapse? Or how does even psychology measure that, or psychiatry measure that, or do they even know the difference?
Okay, well, first of all, I'm a great fan of Laura Delano's work, and often suggest her websites to people who ask for advice. And well, what do I do now? How do I get off this, given what's happening? I don't see these two concepts as being in opposition. It's not like it's relapse or withdrawal. Both phenomena are real. Both phenomena are real. We know that, I think the estimates I've seen are 30 to 50% of people who try to get off an antidepressant experience withdrawal symptoms. And the withdrawal symptoms are not necessarily a recurrence of depression. The withdrawal symptoms, things like chills, diarrhea, headaches, shock-like sensations, visual disturbances. That's not how we measure depression at all. Those are withdrawal symptoms. They're withdrawal symptoms to antidepressant medications like SSRIs. Something else can happen. Someone's depressed. They may stop being depressed for any of a number of reasons. Maybe changes in life circumstances. Something happens. They were very poor. They came into a windfall. They finally got a job. All kinds of things. They might get better because they've been given a drug that turns out is just a placebo, maybe in a clinical trial, maybe in some other way. Or they're given a medication like an antidepressant, or they're given some other form of treatment like psychotherapy, for example, or something else, or dietary change and all of that. Now, what can also happen is they might get better over a period of few months on anything at all. It could be this kind of treatment effect or a placebo effect, or just changes in life circumstances. And maybe a year later, they get depressed again. Same original symptoms. These aren't side effects, and side effects usually don't occur a year later. Mm-hmm. But one of the things that we know is that from data is that people who have improved on antidepressants are more likely to relapse a year or two later, to become depressed again, a year or two later, than people who have overcome their depression through any other means, including placebo.
Wow.
So that's one of the things that two things are both happening. One, you're on the drug, the real drug can cause side effects. The side effects can be very serious. You get off of it, you can have withdrawal effects. Withdrawal effects can be intolerable, very serious, hard to deal with. You come off it, either you don't have those effects or you do and you taper slowly and you get off of it. And a year later, you might get depressed again, you might not get depressed again. It seems like having been on the antidepressant increases the likelihood that you're going to get depressed again. It's a kind of a side effect. The medication is that it makes you more vulnerable to becoming depressed in the future than getting through a depressive episode in any other way.
I think, didn't Robert Whitaker write about that and call it like tardive dysphoria or tardive adonia? I can't remember, but maybe David Healy, somebody coined a name for that. Or maybe it's that the depression feels more permanent after you come off. I don't know. I'm probably confusing things, but that is fascinating. Wow. Okay, so we're getting more questions from the audience. They are just like totally engaged in this. So someone asked, how long can the influence of the placebo effect last? After this certain amount of time, can we assume that we are left with the influence of the drug alone all by itself?
Well, again, I'll take you back to the
Antidepressants only
surgery trial, where the benefits lasted for up to 2 years. That's as long as the trial went, regardless of whether they were in the sham group or the real group. So it's a placebo response at the very least. 3-arm studies are relatively rare, but I have seen some, and I've also seen many studies tracking placebo and drug responses over time. And usually what I have seen both in pain and in depression is that whatever the time course for the real treatment, real in quotes sometimes, seems to be about the same as the placebo response over time, and it can last for years.
Amazing. All right, so here's another question. This is a pretty smart one. They said, I've often heard psychiatrists talk about the placebo effect. When asked why they don't just prescribe a placebo, they usually would say that's unethical. So why is it more ethical to prescribe a drug like an antidepressant that carries a higher risk of harm than a normal placebo?
Well, of course, if you understand that the drug is working positively as a placebo with the risk of working negatively, but only as a placebo, there is an ethical problem with that. So the question is, but what can we do with the placebo effect is real. The response to the drug or the placebo can be very, very large. How do we make use of that? And this is one of the more exciting things that my colleagues and I have been researching for the last number of years now, few years. And that is for various conditions, looking at what we call open label placebo. And that is, we prescribe placebos. We tell a person it's a placebo. We tell them it has no active medication, no active ingredients at all. We give them a bottle that says placebo, no active ingredients on it. We explain that even though they know it might affect, it might work for them, it might help them, that their body has learned from years of having good treatments for various kinds of things, that when somebody prescribes something and they take it, like an antibiotic or something like that, their body has learned to respond with through its own self-healing abilities and properties, and we explain that. And then some people are given the open label placebo, and we have control groups that are not given the open label placebo, so we can see if there's a real effect of having done this. And we've done this now in treatment for irritable bowel syndrome. That's where we first studied it. And it's been done for allergic rhinitis, for test anxiety. There's a study now being done with premenstrual syndrome symptoms. And in area after area, we get meaningful placebo effects, because we don't get it in the treatment as usual condition. And in some cases, it's over and above. We did this, Claudio Carvalho in Lisbon, Portugal, was the lead author on this study. And what she did was recruit subjects with chronic low back pain at a hospital. And they were randomized to either get open label placebo on top of continuing to take whatever pain medications they were on, or treatment as usual, but just keep on the pain medications. Big drop in pain scores in the open label placebo condition. Claudia followed up on that 5 years later. And 5 years later, those gains had been maintained. And whereas before the study, 87% of the patients in the study were taking pain medications for their pain, 5 years later, that was down to 37%. So they cut their medications, decreased their pain with a placebo, knowing that's a placebo. Niels Baga in Denmark has come up with another procedure that he's a psychotherapist, psychologist, been using it with his clients in Denmark, where he has them take an imaginary pill. So let's imagine there's a pill that could help you. What would you like it to do? What now, if it was an effective pill for that, what color do you think it would be? And how large a pill would it be? Okay, I'd like you to imagine the pill. I'd like you to imagine taking it right here in the office. And the person takes the pill and asks, okay, now I want to tell me what's happening with these, whatever it was that they were taking the pill for. He says a lot of his clients found that to be among the most helpful thing in therapy for them. Because what they learned was they can bring this imaginary pill with them and use it as a cue wherever they are. And we are currently in the process of collecting data on that. I can tell you that the preliminary results are very promising.
Wow. This kind of stuff, it literally made me tear up because I just think it's so amazing. Like the human mind, just science is cool. Like this kind of stuff is so cool to me. Amazing. Wow. It makes me wonder. Yeah, go ahead.
That's why I got so fascinated with this when I was an undergraduate student back in the 1960s, 70s, and have remained fascinated with it ever since. It's just a mind-blowing thing.
Well, see, I guess I chose the wrong pill because I have a bachelor's of science in psychology, but I thought I can't do a PhD. That's way too much studying. It's too many years. So let me just do social work. I should have stayed with the original plan. Darn it. Yes. That's fascinating. It just blows my mind. Wow.
If you want to add a PhD, I could. There's.
Can I come over?
You could probably figure out.
Let me come to Harvard. I'll study under you. That would be awesome. No, so that begs the question, because I do this in my own life. I've recently had a health scare, and then I started learning all I could about that certain condition. And then there was all these supplements and food things that you can eat that help that particular thing. So I started really thinking about that, like, oh wow, this let me think of something. Okay, turmeric, right? Turmeric is anti-cancer, anti-inflammatory. It's pro, healing. So if you know that and you're taking the turmeric, are you harnessing the power of placebo in your own home?
Sure.
Amazing.
And turmeric may have some effects that are not a placebo. I have no idea. I haven't studied turmeric, but certainly if you think it's going to help and you're taking it, you're going to benefit at the very least from the placebo response, the placebo effect.
That is amazing. Okay, so let's see. There's another question about real life applications of your work. And this was one of my original questions. Like, how can we use the placebo effect and, to our advantage, especially when it comes to like depression and pain? And also, if you'd like to touch on like acupuncture and hypnosis, someone also asked a question about like hypnosis. So how can we use that power of placebo?
Okay, so there are a number of ways of doing it. We just talked about a couple of them, actually: the open label placebo, the imaginary placebo, harnessing something in your own mind. But there are other approaches that work. Acupuncture is one. There's studies of real acupuncture compared to sham acupuncture. In some studies, the real acupuncture does a little better than the sham acupuncture, but they both have very large effects. Certainly, real acupuncture works as well for depression as antidepressants do, at least as well in the short term, maybe better in the long term. Hypnosis is something that's especially useful for pain control, and especially people vary in their response to hypnosis, and how someone responds doesn't matter so much about the skill of the hypnotist. Learning how to do hypnosis is one of the easiest thing in the world. I can teach it in 5 minutes. Not to do it responsibly, but to be able to do it. But there are real effects, and there is differences in how well people respond. People who can respond well to it can go as far as tolerate surgery with no anesthetic other than the hypnotic suggestion.
Amazing.
But they don't even need to be hypnotized for that. It's the suggestion and their suggestibility that is doing it. There's a guy in Valencia, Spain, Angel Escudero, who does varicose vein surgeries using only suggestion for the anesthetic. Patients wide awake, they're chatting, smiling, joking. He's doing the surgical procedure. He doesn't even bother with inducing hypnosis. He just talks to them about how this procedure might work, how it can block pain, gives them an example with having them do things like imagine taking a bite of some food and noticing how saliva comes in their mouth just by their imagining it, to show them what their ability might be. And some people can do it, and people who can do it, they can do it with the aid of the suggestion, regardless of whether hypnosis has been formally induced or not. So all of those are procedures that can be useful in helping people to take charge of their own experience.
It's amazing. Wow.
Has to it. So important things to know is hypnosis is not something that can be done to you. It's something that you as the subject do. And the role of a hypnotist is like a teacher or a guide to help you do it, just like meditation. You know? So if someone says to you, well, gee, what if I get hypnotized and I can't come out? So what if I meditated and I couldn't stop meditating? Or if I relaxed or I couldn't stop relaxing? It's the same kind of thing. The other thing, be cautious. There are a lot of charlatans out there. You can go pay $25. Well, the price has probably gone up since I've last looked at it. So I'll say $75 into an organization. I'll send you a certificate as a certified hypnotherapist. So what you have to look at, rule of thumb in the responsible hypnosis community, is that you should not be treating anything with hypnosis that you wouldn't be qualified to treat without hypnosis. If you're qualified to treat it without hypnosis, you can potentiate whatever treatment you're doing for many people with the addition of hypnosis, doing it in a hypnotic context.
Amazing. Science is so cool. All right. I think this is our last question. And I'm kind of sensitive. Like, I almost don't want to ask it because I don't want to ruin the mood, but I think I better, just because, you know, people might want to know. So during a lot of our film screenings, and I was one of these people about 6.5 years ago, I would have said, antidepressants saved my life. These drugs, you know, I can't live without them. Don't pill shame me. I really truly believe that they were life-saving, and so many that we meet, you know, are. So what can you talk about, like, that belief system, the phenomenon of just us believing that these are such powerful agents in our lives?
Sure. And it's very consistent actually with the data that we've looked at and we've analyzed, and the FDA has looked at and analyzed. People do get better, and they are only in one condition. They're not taking the drug sometimes and the placebo sometimes to be able to compare it. So this is some of the ways that both patients and their physicians and the clinicians that are treating them wind up becoming convinced, look, I gave this to my patient. Look how much better the patient got. Yes, in that sense, all of these treatments work, but it's not the chemical in the antidepressant that's carrying the burden of making it work. That's the thing. And as a person who's taken one, you have no way of knowing how much of it is a drug, how much of it is your belief in the drug, and so on.
Wow.
Or changes in life circumstances that happen, something unexpectedly happen, and you're doing better, and you misattribute it to the drug. Same thing happens with nocebo effect. So when a drug goes generic, the generic drug is chemically identical to the brand name drug, but now it can be sold a lot cheaper with the generic name. People wind up saying, oh, but the generic, that doesn't work as well for me. And that's a nocebo effect interfering with the actual response.
Wow. It makes me think of all those beliefs we have, just like, you know, if you believe that you're going to end up with these certain withdrawal symptoms, or you're going to end, you know, that this one treatment is the one I have to get. I have to get hyperbaric oxygen therapy. I have to. That's the gold standard. And I'm going to spend $1,000 to get it. You know, it just makes me think of all the things we tell ourselves, and to really question those, and like, how much of it is it just me? I remember this was actually filmed, part of the film, but it didn't make it in the film. But I told the Navy commander, I said, I can't get through school without these drugs. Like, I need these medications to be able to function. And she said, Angie, you're giving too much credit to the drug. You got through school. You did it. And that really was a wake-up call for me, you know? So anyway, Dr. Kirsch, this is my pleasure of my life. I just enjoyed this talk so much. I learned so much from you. You're a never-ending well of wisdom, honest to God. Just scientific inquiry and critical thinking and looking at every little detail. It's just awesome. So thank you so much for spending an hour with me today.
Angie, thank you very much. You've been a wonderful host. The time just flew by, and I really appreciate your kind words. They mean a lot to me.
Thank you so much. All right. So everybody in the audience, thank you for joining this discussion. Thank you for your very intelligent questions. I am increasingly impressed with the knowledge base of our audience. If you haven't seen Medicating Normal yet, please check our website at medicatingnormal.com. We are on Amazon Prime right now in the United States, Germany, and maybe France very soon. Or you can watch it from our website directly. We also have a YouTube channel and we upload every week. So check that out. If you'd like to donate or you need resources or alternatives or maybe books to read, Dr. Kirsch's book is on our website too. Check it out, medicatingnormal.com. All right. Thank you, everybody. Have a wonderful day. I hope you don't get snowed in, Dr. Kirsch, in the East Coast, and you enjoy a great warm day. Everybody, thank you so much.